I learned through, honestly, it was about 15 years ago, through the patients that I worked with who were veterans and told me, you really need to learn some stuff if you want to work with us. So I value education in my own professional development. And I had to do a bit of it on my own early on, reading books and articles and really just asking for resources. And I love that these are available to the community and to clinicians, because if you are working with first responders, veterans, service members, their families, this information is just invaluable. So I'm so grateful that NASW does these and that they have so many wonderful committee members who are veterans, who are involved, that can help inform all the work that we do throughout the year. So with that, there are topics that they recommend and that they find meaningful. This is one of them. And we do these workshops through some education in terms of like slides with content for about 20 minutes, but mostly through panels. So interactive panels that have panel members on them that are experts in these topics and can speak from professional as well as lived experience, which is something you can never find in a textbook. So I'm going to do about 20 minutes of slides just to get us all on the same page. There are 200 of you signed on right now, probably going to be more. So there are people on here that have a lot of experience in this field and people that are just starting out, that are beginners. So we do this first part, kind of just get everyone on the same page. So bear with me if this is stuff that you know. Hopefully I can bring some new information to you, whether you are an expert or a beginner. So what we're talking about today is not just how to support the needs of aging veterans, but also how to bring together different generations of veterans, right? So like we see that through peer support, we see that in different ways, but we're going to highlight a couple of things in terms of like what the generations offer to each other, particularly with a focus on aging veterans and what lessons learned, what they offer to the community, and what they offer to their younger generation veteran counterparts. So there are a lot of differences, right? I just want to start with that when we start talking about the military and veterans and the veteran community. There's branches of service. There are internal, meaning within the military, differences. So what branch, what discharge status someone has, meaning they can have a honorable, other than honorable or dishonorable discharge status, and the reasons attached to that, draft, enlisted, commissioned, gender, age, where they came from, right? Like, so geography plays a role as well. Their era of service, so we're going to focus a bit on that today. Race, ethnicity, sexual orientation, the type of service they had, their MOS, which is really their occupational specialty or their job, really, while they were in the service, the community that they came home to, and their prior disposition. So we're looking at these and more. So when you think about like we're differentiating a class of veteran tonight, we're talking about age as something that is a distinguisher. That breaks off 100 more times, right? So I always like to just say like every veteran is completely different. Every veteran I've worked with clinically, I try to put the assumptions aside and just learn. But this is one distinguisher that's really important to look at, because there are implications attached to it that we can inform ourselves about, and just it gives us a little bit of a head start in terms of understanding where certain eras of veteran come from. So major conflicts since 1940 are listed here. And one thing that was important when we workshopped this a bit, right, and brainstormed how we wanted to cover it. There are differences and there are similarities, things that are universal, right? So some differences are the return process. I'm coming home from service to a certain family, a certain community, right? My needs, what my needs are, what my reintegration experience is like, my medical needs, where I need support, and my timeline of service, right? And then similarities, some of these cross over. So Venn diagram, right? Some of these are in the middle. So the return to family and community, the importance of that, the value in that. Peers, right? That should actually be in both, but same generation or intergeneration peers, there's value in both. Psychological needs, what the desired outcome is. So sometimes you'll get a veteran coming into therapy, let's say, or for medical service, and they want to have an increase in peace of mind or a decrease in anxiety or dental work, whatever that is, whatever that outcome is, right? So like if veterans coming in for care, there's usually something that they want. So that's something that is universal. Values, standards, and more, right? We can add more to each of these lists. So that's where our panelists are going to come in and shed light. So these slides are like little teasers of information, and we're going to go deeper into them shortly. So some statistics as I was researching this that I felt like we should touch on, the fact that as we are evolving as a community and moving ahead, and these prior eras of service are kind of catching up in age. Nearly half right now of all veterans in the United States are 65 and older, and that number is going to increase, right? Which makes sense. The largest group of older veterans served during Vietnam era. World War II is the smallest group. Other statistics here. So isolation rates, like it's said in a lot of places that older veterans are less likely to be at risk of isolation than older adults that are civilians. And I kept thinking, well, what's the difference there? I mean, they might find peers, they might find camaraderie, but then when I looked up the numbers, they're very, very close. So risk of isolation, I think, is similar for anyone over the age of 65. Okay. Financial struggle came up a lot as well in terms of having safety nets and future planning, and then health conditions, right? So like when you think of, I do a separate presentation just on working with aging populations in general, and health comes up a lot, physical health and how that correlates with mental health. But when you think of veterans as a subgroup, they're exposed to environmental risk factors throughout their service. Most of them are, whether it's stateside or overseas. Whether it is exposure to a chemical in combat, in a combat zone, or strain on the back by carrying certain things or different trainings. But exposure to physical, medical, environmental risk factors is a thing for veterans, right? Like if you serve, that is something you're signing up for. So medical conditions as a risk factor for this group, for all people who are aging, all of us are subject to that, but especially for people who have served. There's something known as delayed onset. I think this is like critical when we're talking about this topic. And speaking from my own experience professionally, there are many veterans who come into treatment who are, over the age of 50, over the age of 60. And they say things like, well, I've been okay for the past several decades. I don't know why this stuff is bothering me now, right? Like why would it be coming up now for me? And there is a delayed onset with things like trauma and even depression, anxiety, or post-service psychological disturbances, right? Insomnia, right? These don't have to happen the year that somebody returns home from service. So there are reasons for that. Retirement is one of them, meaning the person is distracted by work and life and family, and then they retire, and there's idle time and empty time. And that, I think, is a point of struggle for many individuals. So that comes up. We tend to hide in distraction and avoidance throughout life sometimes. And then during those quiet moments, that's when you realize there could be something psychologically that has been off, or as a defense mechanism, even like I'm going to avoid this because it's uncomfortable to me. So it makes sense for me to avoid it. But in different life phases also, we are going to look at that a little bit more. We self-examine differently through different phases of life. Right. So this delayed onset is also correlated with, like, as we age, we think of things differently, and we might become more sensitive to certain experiences that we've been through. And you could plug that into things like regret or trauma, and other things as well, spirituality, right? So I always, when I talk about anything relating to working with older populations, I always pull up this chart, because we have this stage of psychosocial development developed by Erickson, and we're all familiar with this. Remember this from school, you studied it, you got the answer right on the test. But this is severely outdated. And I always ask when it's like in person, why is this outdated, right? And people look at it and they're like, well, it stops at 65 and older. And then I always challenge them to think, well, what if it was 65 to 75, 75 to 85, 85 to 95, right? Like if we broke down those categories, they would each have their own psychosocial crisis and virtue developed, right? Because a lot happens after the age of 65 and we don't stop developing, right? Development continues on. So it's always good just to think of that as well. Like this is kind of like the foundational model that we have when we're looking at life phases and psychological development. But I think that it needs a little updating, and there's a lot more layers that occur after the age of 65. Factors that are relevant and can impact a veteran as they age are things like loss and bereavement, right? Like they'll experience losses, some due to traumas or losing, friends to overdose or suicide, because those are risks as well, unfortunately, with this population. Some are natural deaths, right? But still, loss and bereavement, as it comes up, could re-trigger past events. What am I leaving behind? Legacy, life cycle. Again, medical issues playing a role, physical health, relationships, positive and negative, right? Strain from relationships, finding purpose, redefining beliefs and values, and that risk of isolation, creeps in, I think, for all of us. So in general, mental health as we age, there are risk factors, right? So like those were kind of the ones I thought of when considering working with veterans. But when we think about in general, these like mental health risk factors, right? We have the physical health correlation with mental health, cognitive, functioning, cognitive well-being, even stress, different types of stress and idle time, as I mentioned, lack of stimulation, risk of self-medication. So there was this clip I saw once, and it was like two people walking into a doctor's office saying the same thing. And it was a report of physical pain. I have physical pain, I have chronic pain, I have aching. And one person was like 25, and the doctor basically said, exercise and drink water. And the other person was like 70, and they gave them a prescription, right? So I think the older we get, the more in the medical community, doctors are also quick to write prescriptions and medicate things like chronic pain. And some of those are controlled substances. And I've worked with some veterans who have emotional pain that they might be numbing through the use of medication. And when I ask when that started, it's usually from some type of physical ailment that they got a script for, and then it spiraled. So risk of self-medication is a factor as well. And of course, all of these things, we can't ignore suicide. Suicide rates among veterans are double that of civilians. And talking about suicide, because it's such an important topic always to bring up. People 85 and older have the highest rate of suicide. Did you all know that? Probably not, right? Like it's not something we talk much about, but 65, 75 and up, 85 and up, these rates of suicide. And this is with the general population. So this is large scale. And males have higher suicide rates than females. And there are both males and females in the military, but we know that that's, the majority is males. And firearms are the most common method used for suicides. This is in the general population. So if you think about veterans, though, many of them are males, many of them have firearms or access to firearms, right? And then as we talk about aging, that subgroup, the risk level goes higher and higher. All right, so a lot of words here. Don't feel like you have to read them. It's my job to translate. So physical and mental health have that bidirectional relationship that I kept bringing up, that correlation between the two. And there were a couple studies that I pulled up just looking specifically at aging veterans. Poor mental health just being common among anyone who has chronic illness, and it leading to exacerbation of mental health symptoms or even the onset of mental health symptoms. Illness, death of loved ones, sensory loss, loss of independence, ageism, right? Something that affects someone's self-esteem, financial concerns, feeling less mobile, and having increase in impairments could exacerbate already existing mental health symptoms, let's say of depression and anxiety. And then if you layer that with diseases that become more common as we age, it all just, and it's not to say that like if you're working with somebody who's 65 and older, you should do this checklist with them, right? This is all just to kind of paint the picture of risk level associated with certain groups, and this one being one of them. All right, let's see here. This just really speaks to the complexity of cases and that leading to sometimes difficulty in diagnosing and inefficient or ineffective treatment plans and care, which thereby cause worsening health, right? So if you're working with a veteran who's like, I've had these chronic health issues, I've been to the doctor, I've been to the VA, whatever it is, I feel like I'm not getting any better, and they're seeing you for something like depression, let's say, that's relevant, right? That's relevant to ask them like when it started, how long that's been going on, and the frustration attached to potentially not receiving healthcare at the level that they need or the level that they're satisfied with. All right, so a couple slides here really just on the comparison between generations. Again, we're taking a peek at that in a couple different ways. And there were studies that indicated that the lifetime rates of PTSD, I believe, were comparable between younger generation veterans and older generation veterans. However, the willingness to access treatment and receive care was much higher among younger generation veterans. And there's a few reasons for that that were really pulled from this. And all of that just led to, like, you know, a lot of the studies said, well, Vietnam veterans are just much less likely to seek care. And then that got me thinking, why? That's a good question. So panelists, I'm going to pose that question to you. Why might an older aging veteran, someone from maybe Vietnam era, be less likely to seek care? Stereotypes and misconceptions, right? So in general, but specifically with this population, asking about combat experiences, trauma experiences, you know, differences related to gender, politics, beliefs, age, length of service, the idea of gratitude for service. Many veterans, specifically Vietnam era, have mixed feelings, right? Because they were not welcomed home by a supportive community, right? So like there are a lot of stereotypes on the table when we talk about this topic. And this is something that they're definitely going to shed some more light on for us as well. All right, a couple more slides, then we'll segue over to the panelists. Just cultural changes, keeping in mind, like as our community evolves and changes, that plays a role as well, right? So just mental health alone has been such an evolving topic over the past several decades. So I pulled out a few things specific to veteran populations and mental health. So like military sexual trauma, that's what MST stands for, has been something diagnostically that has changed, you know, rapidly over the past couple of decades. Adjustment issues or adjustment disorder. And then the term shell shock and war neuroses actually were the terms used to identify post-traumatic stress before there was a diagnosis of post-traumatic stress. So one, it was just less recognized, certainly less treated. And that change, that shift to the post-traumatic stress diagnosis was the beginning of accepting and validating and destigmatizing this idea of post-service trauma. But then that in itself evolved over several decades as well to where we are now. And it's still changing. Stigma associated with mental health and treatment and services. These are just other cultural changes, right? In general, again, politics, events, world events, current events, local events, healthcare in general, medication, med management, the use of meds, right? There's so many cultural changes that if you think of that crossing over with how the veteran community has evolved and how our communities have evolved in general, there's a lot of layers there. And if you picture this timeline of like politics and society and culture and economy and how that like interweaves with wartime, right, over the past several decades, again, these are things that affect veterans when they think of their experiences of service and then their experiences of coming home as well. So Ed Tick writes a lot about this. This was just like an excerpt. He writes about, if you look this up, evolution of community and just recognizing that as warriors change, the communities that welcome them home change as well. And I think there's no greater example of that than the disparity between Vietnam era veterans and post 9/11 veterans, right? Like the difference of the communities that those two groups came home to really paint, unfortunately, a very vastly different picture of what those communities were like. All right, so on the other side of it, the way that we cope with stress, the way that we manage things like symptoms as they come up, that also changes over time. Have we become more open-minded, more progressive? Have we changed the practices and hobbies that are available to people who might be struggling? Peers are more incorporated, right? Awareness and education. That's why we're all doing this on this workshop on this lovely Thursday evening, right? Like I said, about 15 years ago when I first started out, maybe these were happening, but I really didn't see too much public education about these topics. The way we use language, the way we communicate. I know this was also important to our panelists, so I wanted to bring this up. Avoiding stereotypes, the act of listening and asking versus assuming, and having a level of cultural awareness just to understand a foundation of what to look for and potentially where that person has been and what they've been through. Helping someone tell their story if they want to. Some say, I don't really want to tell my story, and others will tell you, yes, I've never been able to. So needs change and access points change in terms of care. So on our end, as providers, as civilian clinicians and providers, and I'm assuming many on tonight are attending are from that group of people, right? So we have to adapt our services to adhere to these changes and these needs as they evolve. So you want to assess someone in terms of their life areas, but then assess them again, because as that person grows and develops, those needs are going to change. All right. That's my spiel in terms of giving you information, hopefully that's valuable, setting the stage for our panelists tonight. For the next hour and a half, we are going to hear from them. So I'd like to introduce our four wonderful panelists. I think they're all on, Amelia. I'm not sure if we got them all, but I'm going to start. We do. Perfect. I'm going to start just by asking each of them to introduce themselves and why this topic is compelling to you, why this topic, why do you feel this is important? Michael, do you want to go first?
Sure. I think the aging veteran, elderly vets, it's been, I first started when I was a company commander and we were in the Far East in Okinawa and stuff, and we were going down dealing with World War II 50th commemorative was coming up at that time in 1995, and we were sent down to Saipan to do the parades and escort a lot of the World War II veterans from Saipan, which were both Army Air Corps, and Marine Corps, of course. And they were, a lot of them weren't as mobile as they used to be, or they thought they were back the day they made their amphibious landings on the beaches there. They were a great group of military men and women that were there. That was just really nice to see, and you could sit and talk and how much they really enjoyed. So I had a company of about 180 Marines that was down there, and they just wanted to talk to other veterans and everything. And it was just something that from that time on, it grew into that. It grew into looking out for the veterans anytime I could for any of the World War II, especially then the Edson Raiders at Quantico. And it was so much fun. I got so much out of it talking to them about my experiences and their experiences. And so did a lot of my young Marines that had been through a lot also. So with that said, a lot of those aging veterans were just something that became really heavy on me to look out for them, because they were getting older, and there was a lot that they could offer still, which a lot of people just would not let them, or just took them for granted, actually. But they were fantastic human beings, but they were also had so much still to offer to just anybody, whether it be military or shopping at Home Depot. And it really played on my heart. And then as I became, did my intern at SUNY Albany with a master's in social work, I was part of IAP, which is the internship for aging project, which really, opened my eyes, because that was a field in aging and veterans little niche that I felt comfortable going into. So that's
great, Michael. Thank you. Tony, are you comfortable? Jumping in? You're on mute, Tony.
Good evening. Thank you so much for being a part of this webinar. My motivation stems from the fact that I'm 80 years old, and I'm a product of the greatest generation veterans, and have values, attitudes, and beliefs about military service that seem to be somewhat antiquated for a lot of people today. One of the things that I really get concerned about in terms of being my age is there seems to be a huge disconnect between my generation and younger generations. And I think, Anisha, you talked about this to some degree. I'm trying to provide with a more personalized view of it. There's an element of feeling invisible sometimes when I get into conversations with younger folks about military service, about obligation to one's country, service to one's country. It's almost foreign language to a lot of young people. And I'm not generalizing about everybody being that way, but there clearly is a very strong element of that. I'm motivated to try and, in some small measure, bridge those gaps. That's why I participate in panels such as this.
Thanks, Tony.
Yeah.
Edie?
Yes. My coming to talking about Vietnam took a long time before I could talk about it. It was because of the Vietnam Women's Memorial that I really started to heal. And what happened with us, at least the women who served over in Vietnam, I would say probably 95% of them were nurses. And I did intensive care nursing over there in Saigon and in Pleiku. And for me, what happened was, and it did for all of the nurses, you were inserted into certain hospitals when you came, so that you didn't go as a unit, you came as an individual, and you left as an individual, and then you went home as an individual. So we didn't really have like a company that we would talk with, and a lot of the nurses disappeared. I know of a few nurses who committed suicide after they came back from Vietnam. And what I did was I just said, okay, I'm going to pretend I didn't go and get back to being normal. And that works for only so long. And about 20 years after is when I hit a wall, and I knew I was going to have to go get some help. But because I can remember nurses coming into country and they would say, whatever you do when you go home, as soon as you get off that plane, take your uniform off, because you will not be welcomed in your uniform. And this was 69 when I came back. Yeah. And so there were a lot of things too, because we couldn't talk about it. Nobody wanted to hear about it. And we didn't want to talk about it. That it took me a long time to start talking about it. And in being affiliated with the Vietnam Women's Memorial, and I was on the board of directors, and so we would be there every Memorial Day and every Veterans Day, and we would have nurses come, and it was like they were tiptoeing up to the memorial. They were so scared of facing what they saw. Mm. They were so scared of opening up that book that they had so tightly shut. So it's really an interesting topic, and that's why I really have volunteered to do this.
Edie, you already have someone in the comments who said that their mother is a 95-year-old vet and was a nurse, and they're so happy to see you on this panel.
Here, here,
Oh,
here.
Carl?
Okay. To be honest, my story is almost identical to Edie. As a Vietnam veteran, we were treated the same way. We went over as individuals. We didn't go over as a unit. By the time I went to Vietnam, earlier in Vietnam, they went over as units, came home as individuals. So there was no camaraderie once you got home. My main reason for getting involved, and I've been involved in veterans issues for a long time. I'm not a clinician. I'm a veteran service officer. Was really twofold. One, I wasn't treated very nice when I got home, couldn't wear a uniform, called a baby killer, spit on, generally treated horribly. I don't want to still be treated horribly. I want people to see veterans for their worth and their value, especially Vietnam veterans. So that's one of the reasons I try to be active and be on panels like this and go to schools and talk about Vietnam veterans. The other reason is I don't want our younger generation of veterans to be treated like I was treated. I want them to be respected and get the respect that they were due. So that's the main reason that I was treated like shit. I don't want other people treated that way.
Thank you. Thank you all. So you kind of answered this already, but why is it important for clinicians to be aware of generational differences with veterans, do you feel? So specifically for clinicians doing clinical work, why is this an important distinction?
I'd like to answer that. Just for me, for the nurses today that are in the service have a different role than we did when we were there. As an Army nurse, you were a nurse that took care of the people in the Army. You were not really a soldier. You didn't have to go through the same kind of basic training that soldiers do. You didn't have to qualify with a weapon if you didn't want to. And you were there to be a nurse. And today's women are there to be more soldiers, to be more integrated into the service from what I've seen. And therefore, they're going to deal with it differently. Although it's interesting because we had on our board a gal who was sent to Iraq for 6 months. She went to Mosul, I think it was. And that was an area where they had a lot of traffic. And she was like a triage nurse. And she came back after 6 months and she came to a board meeting. And I looked at her and I thought, oh my gosh, I wonder if that's what we looked like when we came back. Because she looked different. She was different than when she went over because of what she'd seen and what she'd had to do. And I turned to my friend Diane, who's the founder of the Women's Memorial, and I said, did we look like that when we came back? She said, yeah, only worse. We were there for a year. So it depends on what kind of nursing they did over there. It depends on what kind of a job that they have. But I think that it's really important that the people that take care of the veterans realize that each one is totally individual because they each did something different. They each approached it differently because of how they grew up. And one of the things that I really saw on our board was that those who, Diane and I got out after our 2 years. And we had PTSD pretty bad. Some of the gals who had served in Vietnam and stayed in the Army for the full 20 or 25 or however long they stayed in, it was totally different for them. Because they had somebody that knew, they didn't necessarily have to talk about it, but they were still in familiar territory. When we came back, we were so out of the Army kind of thing that, and you couldn't talk to anyone because nobody wanted to hear it. So I think that from what I have seen of the women who stayed in, that their PTSD did not seem to be as, I guess, well, violent, I would think, I would almost call it, than those of us who went through the trauma and then got out and didn't want to have anything to do with the Army ever again. That's all.
Does anyone else have thoughts on this? Really helpful, Edie. Thank you. Tony, you're muted.
Yeah, regarding the issue of working with people of our generation in a clinical setting, I think it's really, really important that any clinician that wants to do that gets in touch with the stereotypes that he or she may harbor regarding veterans in general. For instance, let's look at our panel. 3 of the veterans on this panel saw action in Vietnam. I didn't. I spent 20 years in the Air Force. I went in 1966. I was there during the buildup, but the career field that I was in, air defense, didn't get me over to that place. It's interesting that I'm often treated as a Vietnam vet. I'm a Vietnam era vet, and there's a big difference amongst veterans who were there and people like myself that were Vietnam era vets. There's a pecking order. There really, really is a pecking order. And for anybody who's going to do clinical kind of work, to not understand that or not look into that, to get a real sense of the individual person's military career in specific terms, where he or she did serve, and whether or not they were in harm's way or not, if they did serve over there. I think that's absolutely essential. The other thing that I think is important is, and this is rather basic, there are really wonderful stories to be told by a lot of people of our generation, if given the opportunity. I hope you have really, really good skills at listening, because that's absolutely essential. Sometimes that's just therapeutic among members of my generation, to just be able to talk and to reveal our narrative and our history and our experiences. That's a wonderful connection to make, and that can be downright therapeutic.
Great, Tony. Does anyone else want to speak on this? You don't have to all answer every question. I can.
What's the question again?
Just for clinicians, like why clinically is it important to understand the difference in generations of veteran?
I think it's not even just generations. I think it's in what they did also.
Yes.
For instance, in talking to some of the guys, and there was this one guy from the first CAV association that I became friendly with. And he said, to me, your experience was almost like night and day to ours. I mean, we were out in the bush and we'd have a fight, and then it'd be calm for a week or so, and then we might have another fight. But he said, you had these guys coming in day after day after day, brand new casualties. And it's like, we never saw the victories. If there was a victory, we still got the wounded. And so it depends on what they did, I think, that, because because it was almost like we had the negative of the positive of the photo over there when we
Mm.
were there.
Does anyone want to speak to that concept of delayed onset that I had mentioned? Why something might come up for someone decades after, let's say, it occurred? Because I think that's a common misconception I've seen where someone's like, well, you know, that happened 40 years ago. Why would that bother you now? Right. And
Yeah, I can speak to that, I think, to some degree. I think, and this will be a bit of a generalization, I think most of us who have served, when we see a headline about something that happened somewhere around the world where we've got, I think we're actually deployed in something like 140 countries as we speak. When somebody's in harm's way and is wounded or killed, there's an element of empathy that's automatic. You think, I mean, I'm brought back to names and people that I associated with and served with that are long gone. And sometimes it comes rumbling back in for me. I can't say it happens a lot or that I become preoccupied with it, but there is that glancing blow of sadness, if you will, of a sense of loss that dates back 30, 40 years for me. And I think that's a real issue. The other piece of it is we've been at war for a very, very long time. My life has been, I mean, it's a history of warfare as far as the US is concerned, most of them undeclared at this point in time. But I think that has taken its toll in terms of it's kind of diluted the intensity of the experience for those who have served in combat, and it becomes almost like it's almost covered like it's a game, a video game for too many people. And I think we become somewhat what's the word I'm looking for? Numbed by that. But again, if you have served, that's a very, very troubling element to witness or to see. That people talk numbers, 50 people killed, 13 members killed during the evacuation of Afghanistan, yada yada yada. There's a much deeper response, I think, for those of us who have served. I just think that's something that makes us a bit different than the general population.
And Anissa, I think with the late onset, it has to do with when I got back from Vietnam, I had to get on with my life. I didn't have time to worry about not being welcomed home, not maybe having post-traumatic stress. I didn't have time to worry about that. I got married. I was starting a family, tried several jobs before I found one I semi-liked. I did not have time to worry about how I was treated in Vietnam. I suppressed it. I personally dealt with it by I wrote a play. I wrote poems. I wrote stories. That's how I dealt with it. But I didn't have time to go to the VA to seek help or anything like that. As we get older, and I think with a lot of us, as you get older and your responsibilities diminish, you may end up being retired. Your spouse may have passed. Your kids have moved on. You have more free time on your hand. You have more time to dwell on what happened 50, 60 years ago. And I think that's where we see the problem with older veterans, because now they're old. They're thinking about what happened back then. Oh, geez, I should have done this. What about this buddy that didn't make it? How come I survived and this one friend of mine didn't survive? So I think that's what it is. We got on with our life. We were children. Our parents were from the Depression. We were told, suck it up, Buttercup. Go back, go on. Get the job done. Don't worry about You don't have time to worry about that. You know, I think it was just a generational, different generation, and now we have time to maybe worry about it.
Well said.
I think too, is somebody else gonna talk? Go ahead. Yeah, I think too, for me, just in listening, one of the things that happened to me and to a lot of the women that I've talked to, is that when we were nursing, because we had, especially in the intensive care unit, you'd work really hard and then you'd lose somebody. And this kid was like my brother. I had two brothers. They were younger than I was. And the average age that we took care of was between 18 and 23.
Yeah.
And so you'd lose these guys, but you didn't have time to grieve about it or anything. You just had to keep going. So, and I thought about it later. I went in July, about October, I shut down. We worked 12 hours a day, 6 days a week. So you didn't talk about it on your day off because you wanted to get away from it. And one of the biggest things that I had to do when I started dealing with my PTSD, I would say that first year was mainly grieving for the loss. The loss, not even the guys that died, but the ones that were injured that you knew were going to go back home and only had one leg, or, you know, had one eye, or whatever it was. And do all of the grief that you had stored up for so many years. And I still grieve. You know, to me, it's the saddest thing. I can remember going to the wall one time when I had to be in Washington for business, and I went to the area where my boys were, the timeline. And all of a sudden, I just started crying, and I just started saying, I'm sorry. I'm so sorry that I couldn't protect you, that I couldn't save you, that I couldn't do what was right for you.
And grief in itself can have a delay.
Yeah, absolutely. Yeah,
like,
no, I didn't start grieving until I started dealing with my PTSD. And then it really started popping out.
And then that sense of responsibility that you referenced, Edie, I think that, you know, that's something that we could bury deep for years if you have that feeling, right? And that's, again, that
Yeah.
protective mechanism. So you guys brought up really great points here. And Michael, I know you had a point also, but I did want to touch on, Tony, what you spoke about. It kind of sounded like re-triggering. Would that kind of qualify what you were saying? Like somebody could be re-triggered by seeing something on the news or hearing a story, and it might bring up something from a past experience?
Yes, yeah, I think I used the word, there's an element of empathy, immediate identification with, oh, here we go again. When are we going to learn our lessons about this sort of stuff?
Mhm.
You know, and again, one of the things that the way we report putting our young people in harm's way is, to me, is rather appalling. It's like a video game. And also it's a case of, well, the war is over. Well, guess what? For some 2 million vets of Afghanistan and Iraq, the war isn't over. They're carrying a lot of the wounds with them as we speak. And there is almost the dismissal of, when the shooting stops, the war is over. Therefore, you don't have to you don't have to attend to those who were in harm's way and did serve their country. I think there's still an element of that out there. There are people who clearly disparage the whole idea of service to one's country, and I think that's something that us older folks really struggle with. I suspect everybody on the panel would validate that as well.
Michael, I know you had a point also that you wanted to bring up.
Yeah. No, I mean, it's just the older I get, the more I realize about the late onset. And you know, I retired in 2006, and it's when you're at that moment of peace that something comes right back and it reflects back into your memory. And you know, the grief, an apology. You always wonder what it would be like. And earlier today, when we had our meeting, you saw that from Columbia University, she was friends with a Marine who I worked with. And a lot of grief came back because he committed suicide. And, you know, I just, you know, you wonder about it, and you look at it. The generational differences, though, you know, like, for instance, between the Vietnam and the nowadays veterans, is that we're younger and we're catching up as time goes on, and the Vietnam veterans go, you're going to see a lot of the same issues rise up in us, our loneliness. Because when you lose, the longer you stick around, the more you're going to start losing multiple or have multiple losses, from a dog to other people you served with to you know, family members and everything else. It's just one of those things. So you sit there and you realize how much it had impacted you, and it keeps increasing as you get older, probably because resiliency is getting weaker as I get older too. And you know, it's just, you know, goes back to also like Edie's questions. There isn't a day it goes by at times when something goes in my mind, could I have done this different? Could I have done this? And, you know, would this have mattered, or would this have changed history, or with the timeline? And you sit there, and when you talk to some of the other older veterans, like I was fortunate enough to talk to World War II veterans, and I would go, man, that's the way I feel. Oh my God, that's exactly what's happening with me. This is like, and then I would talk to a Vietnam veteran and I'd be like, no kidding, that's exactly what the Korean War vet that said the World War II vet said. And now I'm saying it, you know. And so as that goes on, it's interesting in how much you really love you got to love people to understand what they're saying. And if you don't, I think that trauma could do that trauma will eventually take you. And it's not us with resiliency to let that happen. We have to, a vet that's talking to a counselor or talking to somebody, and they go, wow, this guy's never talked to me. There's a reason they're talking, and it's probably they don't know why they're talking to somebody, except that loneliness now needs to be neutralized. So, because I don't talk to a lot of people, and I like it because I don't talk to a lot of people. Don't get me wrong, but you know, after the Afghanistan incident, it kind of set me off again. And you know, it's like, yeah, people don't know, man. I mean, the hurt, and then you don't want to tell people because you don't want them hurting either, because you know, a lot of people can empathize with you, but that kind of pain, you don't want to spread it.
These are great points that you all brought up. I took notes on a few of them so we can kind of tie it back. When we talk about, oh, go ahead. Sorry, Edie.
Yeah, in listening to that about people not understanding, I can remember at the dedication of the Women's Memorial, my daughter came down with me. She was in college at the time. And she came back and she said, Mom, there are guys still wearing their uniforms at the wall. What's with that? And I said, Gwyneth, your brother is now 19 years old. And the most he's ever really done in the wilderness is floated down the Delaware with his Cub Scout troop, a Boy Scout troop. I said, think of him being drafted and placed into Vietnam in a jungle where you live in fear. And actually, you didn't even have to be in the jungle to live in the fear. To live in fear for a year, he would come back a different person. A different person. And I don't think she had ever thought of it before, because the war really hadn't affected her. She wasn't born, you know. But it really, because they were all 19 and 20. And they had just been living their lives in the US and then were plunked into this country where you didn't know who your enemy was because they all didn't wear certain uniforms. They all looked the same. And so you didn't know if you were going to walk down the street. One day we had, when I was in Saigon, we got notice about 8 o'clock in the morning that we were going to get 9 in. And they had just been standing on a street waiting for a bus. And somebody drove by on their little motorcycle and threw a bomb. And so you never knew, you know. So I think that realizing that these people who come for help were somebody else before, probably a totally different person than they are now. And they wish that they could still be that person, but you can't.
You know, if I may, Edie, you really point to something that I think is missed by a lot of civilians. When somebody signs up to be in the military, if there was a contract, I often call it the unlimited liability clause. What you're basically saying is you're entering an institution, and that clearly is saying to you, if you're going to serve your country, there's a possibility, depending on the career track you're on, or the experiences you have, or the assignments you receive, where you could either be wounded or killed. This is a fact of life that a lot of people just don't understand. And when you come back from an experience like that, and you go back into the civilian world where there's been a lot of criticism of our culture being somewhat narcissistic, it really takes its toll on individuals who have made incredible sacrifices or have witnessed somebody making, you know, the ultimate sacrifice, as it's often called. I think these are the kinds of issues that anybody who's going to work in a clinical setting needs to be aware of, needs to be sensitive about. And it's really important that they get an understanding of what that person's military experience is like. It's not monolithic, but clearly those who have served in combat are going to have very different perspectives than those of us who did not and served in the military. And Edie, there's one thing I wanted to say about you. I see you as one of the grandmothers of what amounts to a lot of women in the services today that are serving our country in an incredibly good way. Once upon a time, all you could be when you were a woman is a nurse or maybe a doctor, but there were very few career paths that women could take, and today it's just unbelievable. I mean, we have women in the Air Force, fighter pilots. I mean, that was unheard of back in the 60s and 70s. Women couldn't fly. They were women. That was kind of the the macho BS attitude of of the institution back then. But they are incredibly wonderful in serving our country, and it should be celebrated more. And that's another piece that I think civilian therapists need to be looking at. The woman's experience in the military can be an extraordinarily positive experience. The headlines don't say that. There's a lot of criticism about what goes on, but there really are some incredibly positive things that are happening for women today, I think, in the military. And I think that needs to be addressed as well.
No, I agree with you. And one of the things, I had lunch in September with a group of people, and there were 2 West Point gals over there. There were students. One was a junior, one was a senior. I don't think they call them that, but whatever. And I turned to them before we left and I said, if you're ever in combat, be sure and talk to other women, because women process this differently than men. You know, you can't, there is no one line for how to deal with. You know, it's not like everybody's gallbladder comes out the same way. You know, it's and women will deal with it differently. And so I think that that's one of the important things to remember, because I remember when I went to Castle Point and I was given this wonderful young, you know, psychologist. He was just wonderful because he was open to finding out how a woman would have PTSD and what we could do about it. He was sitting there, Vietnam vet woman, PTSD, what's this? You know, but we worked at it and he was just wonderful. But I think that a lot of women were not going at the time to the VA for help. Now more so than ever before, I think, but that really helped me a lot.
Yes.
So, great ideas so far. I have a few things that I jotted down over here. This idea of engaging in conversations about mental health with an older vet. What would be some suggestions for communication, effective communication in screening for things, let's say like depression or suicidality? Like those statistics really hit me when I see that veterans are twice more likely to attempt to take their own life, and people over the age of 65, 75, 85, that suicide rate increases. It's just alarming to see that. And I would never want to miss something or not ask the right thing to somebody who might be struggling, and it's masked maybe by trauma or physical ailments or other things that they may talk about, but underneath there could be like a depression that's being missed. So what would you recommend in terms of screening questions or identification questions with that topic?
Nisha, you touched on the sense of loss. I mean, I don't know who coined the phrase, the autumn of our lives. Our expiration dates aren't that far off. And one of the things that clearly has occurred in my life, and I'm certain for anybody else who's near my age, is the sense of loss that we've experienced of loved ones. Early on, maybe our parents. I lost my brother 7 months ago. He was 4 years younger than I am. And I think for somebody who is in the initial stages of joining with a veteran patient or a client, it's really important to get a sense of where he or she is at in terms of loss in personal life, family life, and friendships. I mean, it's a really, really tough season to be in. And again, I think it's exacerbated even further when you're dealing with somebody who's been in combat and witnessed the death, of the person next to him, or maybe was wounded as well, kind of thing. But those kinds of losses seem to pile up, I think, and I think they're revisited as we begin to experience the natural consequence of aging and the loved ones around us that we lose. I think it's important to get a sense of that.
And Nisha, again, I'm not a clinician, but and Mike had mentioned this when those 13 soldiers were killed in Afghanistan. That's what triggered me. First time I went to a clinician. First time I went to a VA psychologist for the first time, And what I like what she did, because, and I think this is true of a lot of veterans, especially combat veterans, we don't dance. Don't take me for a dance around the room and try to find this out and that. Ask me.
Yeah.
Be quite frank. We know the realities of life. We've been around for a while. We know a lot of our comrades have taken their own lives. So if you get a hint that you fit for whatever reason, even if you don't get a hint, and that's the ones that are most dangerous, the ones that you don't get a hint. As a service officer, I ask the guys all the time, if they're putting in a claim for depressive disorder, PTSD, anything like that, I'll come right out and ask them. Again, I don't dance. Most of the veterans I know don't dance. Just be honest, be frank with them. That's what they like. My humble opinion.
Mhm.
Right?
I think a lot of times when I go in, the first thing I'm wondering as a veteran, because there's a couple of things I wanted to know is one, I'm not homeless, and two, I'm not mentally unstable. And so if I'm talking to a counselor and being, a social worker myself, I want to earn the trust of them, but I want them to earn my trust first, because I don't want to expose myself to things that I feel I'm going to be exploited against. And a lot of that's a misconception, but it's real. And it's something that I really don't want to divulge unless I can really trust that person, because what I'm telling you is deep in the soul. And and that's like any veteran, is so deep in the soul that I don't need that scar reopened. I don't need to be bleeding at my age in order to get something done. It goes back to what Carl was just saying. I don't dance in that, and I like that phrase, Carl. But realize as a clinician, the first thing that they're thinking is how do I trust this person? I'm here, but now how am I going to trust them? And that's up to the whoever you're seeing, the clinician. They have to earn that trust.
Edie, any recommendations on approaching conversations around mental health, suicide, depression?
Hmm. I think at least because I can really only speak for the women because I have been associated with them and have seen what's happened with the women vets. For me, women seem to be pretty adaptable. And a lot of the women that serve that I know of are still doing some kind of work. Whether it's most of it now, because of our age, is donating our time, which is wonderful. But it gives us a purpose, a reason for getting up in the morning. And I think that that's the key for, at least for me it was, is that I need to feel like I'm still a functioning member of society. That I'm not just sitting in a lump waiting for, the Undertaker to come. I'm going to be 80 next year, and I just stopped nursing 2 years ago. I was an operating room nurse. And I worked 2 days a week, 2 10-hour days, and I loved it. And I still do. But for me, it really saved me, especially during COVID, because in the operating room, you're all covered up anyway. They closed it for 3 months, and then they opened it again. And we all went back, but I got to talk to people. I got to talk to young people. I got to practice my profession. And I was really lucky. I know I need to feel like I'm still giving to society, like I'm still a member, that I'm not just a lump, you know? And I think that's one of the tough things for a lot of people as they get older, that you have to really work at making yourself a member of society. Because unlike other times, you know, when you're young, when people say, come on over here and do this, people aren't going to say that. I need to get out there and give. And that's what I do now for veterans groups and the garden club and all these other things that I belong to. And that's what makes me feel like I'm still here. Like Edie's still here.
Edie, that makes me think of also like the connection to peers, fellow veterans, others who have served from same generation, but also from, I think it was maybe Carl who said like or Michael might have been making sure that the younger generations of vets don't experience necessarily what you went through in terms of lessons learned and things that, you know, community failed at, right? Can you speak about like the connection between veterans from other generations and the importance of that in terms of this, like, you know, sense of purpose maybe that Edie's referring to? Is there a connection to that or something that you feel is relevant in bringing up?
Well, one of the things that I think I heard Edie say was, and it really hit home for me, and that is at this stage of life to really find paths that satisfy my profound desire to give back, to continue to serve. That's something that I clearly struggle with. I would like to do more, and sometimes there are limitations that prevent me from doing more. But I think that for those of us who have served, that maybe for some of us in our DNA at this stage of our lives, to be able to be fortunate enough to give back and to maybe provide some contribute to positive outcomes. If I may, though, I'm looking at a text from Mona Lee Youssef, and she touches on something that I think is appropriate to address. I don't know what the heck. I'm not sure if I have the right one here. No, I'm sorry.
You want me to read it, Tony?
Yeah, go ahead.
One thing I've experienced as a therapist, analyst working with military service members and veterans from different ages and eras of service and conflict is how the military training to dissociate feelings in order to get the job done.
Yes.
Hold on, it scrolled up, or make it through incredibly dangerous or conflictual war situations makes it that much harder for them to feel when in therapy. That it's okay to connect with their feelings, to sometimes even know how to access their feelings, and okay to share those with me. Yeah.
I would add to that also, because through the training, not everybody goes to war, but through training, we're taught to solve our own problems.
Yes.
And through that, being taught that you don't go seek help. And that's one of the biggest things, even from all the generations that I know of. So that besides what she hit that out of the ballpark, I think it was, Mona Lee hit that out of the ballpark, but also add that we are, that's why we're not going to go see somebody. That's one of the biggest things, because we're taught to solve our own problems. And, it's just the way it is.
Yeah, and if I may, I think one of the things that complicates this this issue is the mental health movement in our country. Today, we look at mental health and being in terms of being in touch with your emotions and being able to express them, yada, 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 some version of that. Somebody who's been immersed in a war setting, been in combat, where they've learned, no, emotions have no place here. It's a cognitive issue that you need to deal with, and your emotions will get you in trouble if you allow that to get the best of you in say a firefight. I think that's a big leap to come back to a setting where it's really okay for you to spill it all out, get it all out. I think that's a huge gap for a lot of particularly combat veterans to have to deal with. I think that's absolutely spot on, and that I think clinicians need to be sensitive to.
But I also
like to-
think it needs to go beyond that there, Tony, is
Yeah.
that not only we talk about this, but war, the thing about war is that, it affects everybody. And it's not inclusive to just the veterans that 1% of us that, somebody shot something at us. But what it is that there we go in the training, we're taught that, the war doesn't stop in our training. We keep moving, and you grab whoever's wounded or dead, and you give them to the next station so that you keep on moving. And that's the way we're trained, and that's how war works. And you don't have really that time to mourn or that time to pick up. And especially, if you're on alert and then off alert, off alert for 24 hours, they're back in the old days when you used to do air alerts and stuff. It's like, that keeps you at a high state of mentalness, a high state of awareness, mental awareness. And a lot of those, I think, have impacts on us as we get older. And, it's just like what I'm saying is that it's just not that 1%, because all of us, the effect of war is not inclusive just to those vets. It's to everybody. I mean, think of the families that have been affected. Think of the neighbors that have been affected. I mean, there's a lot. And for me, I actually have been there. I feel a lot more fortunate with Vietnam vets. They weren't accepted. And if you said anything about combat fatigue or something, you're going to get crucified. Here, now all of a sudden PTSD, is very much, everybody says, oh, you got PTSD or and you get checked for it and you got it. It's like acceptable because it's understandable. So I feel a little bit fortunate in the generation versus the past generations. So, I mean, it goes all the way back to World War II, where Patton slapped a couple of the shell-shocked people in the medical tent. So, in the Vietnam veterans, you get operational fatigue. Are you kidding me? And I feel fortunate enough at my time, there's a lot more understanding about what's happening.
The solution when I was in, if you had an emotional problem, which would be PTSD, was go see the chaplain.
Yeah.
You go see the chaplain, then you go back to your unit right there. And the chaplain didn't do a thing for you. Maybe you'd have, maybe you get a cup of tea, a cup of hot chocolate, a couple cookies, and you go on your way. So that was our emotional support. Go see the chaplain.
I think to say one thing too, that I think that if you've been in combat, that you really have functioned as a team. I know working in the intensive care units in Vietnam, the teamwork there was amazing. And you depended on each other and you trusted each
Yes.
other and you worked like a clock works, and you come back to the States and no one's working like a team in the civilian life. And there's no way that you can find a team like that. And I know that in talking to some of the Vietnam vets, that was one of the big things that they missed, was that teamwork, that unit
Yeah.
that worked so well together that you're never going to find again.
Yes. There's a metaphor that I've used over the years in terms of working with other veterans. And if you take a pebble and you drop it in a pond, where it hits, that would be veterans who have experienced life-threatening situations, be they fighter pilots, be infantry, whatever. And each concentric circle after that takes you further away from the intensity of that kind of experience. I think for therapists to figure out where that client is at in terms of where the center is and where their experience was in the military can be of tremendously good use to them in how they work with veteran clients. I don't know if I'm making any sense with that at all, but
Yeah, I mean, it's the layers, right, Tony? It's
yeah.
and the layers and the overlaps, and yeah, I mean, it's all, that's where all of everything is that really people want to talk about, and sometimes they don't know how. So it's our job to help them sort that out and navigate it, right?
Yes.
So the one comment question that we just naturally kind of came up and we grabbed it. I was going to wait a few more minutes, but I have a couple other questions, but it seems like the engagement's really good. I'd love to open it up for anyone who's attending. If you want to use the chat box and put in any comments or questions that you would like for the panelists. If nothing comes in, I'll move on to a couple other questions, but feel free to pose questions to the group that you would like them to answer. And while people are doing that, one of the things I wanted to bring up are just like how, just from a personal experience, how your needs have changed over time and highlighting that, and I think anyone can do that. But I would be interested to hear from veteran perspectives, like, hey, my needs have changed in this way over time. And that's something that I would, really want like a therapist to know. Like 20 years ago, I needed this, but now this is the primary thing that I would want to focus on. Does anyone have insight on that?
I don't think I'm as needy as I was when I was younger. I'll be honest with you. I mean, it's something
That's
where
good to know too. Yeah.
Yeah, it's nice to be able. I get enjoyment out of. I sometimes I wonder if helping a vet in doing therapy or clinical stuff is for me or for them, and I always have that question in my head because I learn so much more and I find so much more peace in myself as I get older by doing that. So a lot of it, I worked in oncology, cancer, for a medical social worker. And, I get a lot of self-healing from.
The way I would describe it is when I first came, it was like having a giant sore that you would touch and it really hurt. And as the years went on and I healed more, first of all, as I healed more, I didn't feel like touching it anymore. But it was healing. Didn't go away. The sore was going to be there, but it was covering over and it was okay with me and I was settled and it wasn't the focus of my pain anymore. And I still need, and I still go and see my psychiatrist at the VA because I'm not cured. I'm balanced right now.
Mm.
And that's what I wanted to be, was balanced. And it's kind of like, because I am on medication for depression. And I said to her, I don't want to feel high. I don't want to feel, I just want to feel normal. Right. And so for me, it was the getting back to some kind of a norm for me, so that I wasn't dreading all the time that it was going to sneak up on me. It doesn't sneak up anymore. Does that make sense?
Very much. Yeah. One person asked if culturally,
Can I say something first?
oh, sure, please, Mike.
Yeah. I know and I want everybody to understand that there's three of us, like Tony has said, that had been with the combat inside. Tony wasn't, but what I want you to understand, we're talking veterans in general. And I was reading the comment here, and I'm not going to say it's a great comment, but issues of war, but it's issues of military in general. And I just want that to be known, because I have a lot of friends that were Cold War that have issues from being up and down, up and down, up and down, from all the alerts they did, fly outs to exercises and things, and you're not told anything. And you don't know if you're going in for real or in for real and things like that. So I just want to let you know it's veterans also that as a whole, not just I'm proud of what I did and everything, but I just want it to be.
Thanks, Mike. So someone asked if we feel culturally we are more accepting of Vietnam veterans now. I think we've kind of touched on that, but would anyone like to speak to the difference in community and maybe the acceptance of versus, perhaps what was experienced?
In general, I think we are more accepted. I'm not one of the ones that dislike being thanked for my service. I'm glad that people do that. It doesn't bother me, but I think people are every once in a while are shocked when they find out that somebody is a Vietnam veteran. I still think a lot of Vietnam veterans hide. People don't know they're Vietnam veterans. They didn't join organizations. Some of them still haven't sought help from the VA. I get Vietnam veterans at least 2 or 3 a month that have never sought help with the VA. Now they have to. They have some illness that they have to go to the VA now, but they've avoided it their entire lives. But I do see more of an acceptance, and I think a lot of that has to do with the younger veterans. You asked earlier, Anissa, about the younger veterans and the older veterans. I think that's part of the whole peer connection, and I think that's very important. Older and younger veterans being together and talking with each other, and I'll talk with a younger veteran. Said, "Damn, I feel that same way." I didn't realize you guys felt the same way, and so yeah, I think it's gotten a lot better. I really do.
Mona asked a question about lesbian and gay military service members. In the at the risk of offending some people, there's been a measure of improvement over the years since I served. I can remember if somebody was identified as gay, they were gone the next day. gone the next day. There was no if, ands, or buts about it. And there was clearly extraordinary amount of prejudice and discrimination against anybody of that persuasion. And that I think has changed remarkably over the course of 50-something years. Not to the extent where it should be, but it's clearly, there's a measure of improvement. And I know that offends a lot of people when I say that, but I'm looking at it from a historical perspective. I had a young man working on my staff. I was on a joint command, and he was a fine enlisted fellow. And somebody turned on him, and he was gone in 2 days. There was nothing that could be done about it. Nothing that could be done about it. No matter how many appeals were made, he was gone. And that was something that occurred way back when. And I think it was the same for a lot of young women who came in, particularly after the draft in 1973, when the draft ended. We were seeing far better recruits and potential leadership coming out of a lot of women that were applying and coming into the service than had ever been before. Sadly, the headlines are out there, and clearly the negative is very, very much emphasized. And there have been historically terrific improvements that have made over the years. And let's put it this way: I'd hate to see us go back to the way it was 50 years ago.
Thank you, Tony, for
Yep.
correcting that. Yeah. Someone had asked, how do you feel that aging has strengthened your healing process?
I think it's weakened me in order to strengthen me, believe it or not, because it's made me, when I was younger, I definitely wasn't going to go get any help or even believe I needed help. And as I've gotten older, it's weakened me enough to say, hey, you know what? Maybe talking to somebody isn't a bad idea. And we'll see how it goes. And then you go through this process. So I think aging has helped me become wiser. If you looked at the psychosocial chart and everything. So hopefully I'm on that side versus still being hard-nosed, stupid.
Not to belabor the Vietnam issue, but I think just the opposite of Mike. I think it has, I don't know if weakened is the right term, but I'd like to say I didn't want to go for help when I was young because I was strong. I didn't want to go for help because I didn't want to be belittled. I didn't want to be mocked. So I would avoid going for help. It was not something I chose to do. As I got older and it became more acceptable, or I stopped giving a rat's ass if people liked whether I was a Vietnam veteran or not, I would seek help. So I don't know if it's the age or the attitude that changed, or both.
Well, I mean, I think all of us have had incredible role models from the greatest generation. All my uncles, my father, all served in World War II. And one of the things that we basically dealt with as role models, they basically came back, never talked about it. I had an uncle who received the second highest you can receive in the military. He never talked about it. We found out about it after he died. And he lived into his 70s, and he died, and we're going through his effects, and there it was. One of the things that I think has happened is the whole idea growing up as a boy at 18, you knew you had to go in and register. That was a rite of passage back in those days. It was for many of us kind of a noble obligation that we were going to be doing something on behalf of our country. I don't know if that exists anymore, but that was an issue that I think stayed with me for my entire career in the service. And I used to really get a kick out of my uncles, because I wasn't called Tony when I went home. I was the officer. I was the only one who'd ever been an officer in my family. We used to have a lot of jokes about that sort of stuff, but they were very proud of the fact that I was doing that. And I was really, really very, very much touched, by their positive feedback. That's something that I don't know exists very much anymore, unless you're a family where there are generations that are still very much involved in military service, generation after generation after generation. If we didn't have that today, our volunteer service would be in a hell of a lot more trouble than it is right now, because there's really a lot of people out there that want nothing to do with the military or any form of service to the nation.
Well, if we're speaking about that, I have to put my 2 cents in. I think, and I'll be shot for this, that there should be a draft.
Oh,
Mainly because if everyone in the country is involved, then they're going to pay attention.
yes.
I think that's why we were in Iraq and Afghanistan for so long, because we had the volunteer army and they kept sending them back 3, 4, 5 times instead of getting new people to go over there. And it didn't affect anybody else in the country. You know, one of the things that I really firmly believed was, maybe it's because I had one brother who was a Marine and one who was arrested for protesting the war. And I believe if the protesters had not been there, we'd still be in Vietnam. That it was, these people, and because it meant something to them. It affected their lives, what they wanted to do, what they didn't want to do. And so they protested. But with Afghanistan and Iraq, nobody was protesting because it didn't really affect them. Just my 2 cents, sorry.
Yeah, Michael.
No, I get.
Oh, you have to bounce off.
yeah.
Thank you for your insights, really, and everything. A comment just came in. I just want to read out loud. I think it's great. I wish my father, World War II vet, who had passed away and served proudly, could have heard you all in this presentation. He didn't want to talk about his experience. Thank you for deep
Sure.
empathy for us.
Yeah.
Beautiful.
Yeah. Yeah.
So, yeah, go ahead.
The VA just started a program and they're trying to roll it out up in our area, House Point and Montrose, where they have either veterans or even civilians trained to interview veterans, to get their stories, not only for posterity, not only for history, but if they go to a therapist, it's much easier if the therapist already has this veteran's history. So that's something they are rolling out in our immediate area down here where Edie and I are. And I think that's a good thing. We lose that history. And it's not history, get back, it's not the history of the war. It's not the history that you read in history books or in textbooks.
Yeah.
It's the real war. It's what really happened. And we lose that. We lose that. And I also want to point out for everybody who's listening, I think I was the only enlisted man on this panel. I just saying, to all the officers who are listening, so there's only one person that's really in charge. I wanted to point that out.
So
Yes.
true.
We won't hold that against you, Carl.
So my last question I want to pose is, you've brought up this idea of like generational knowledge and making sure the communities are equipped to handle the needs as they come up, perhaps in ways that they weren't for you all. So what would be one thing that you hope that strengthens in our communities as we continue to serve veterans who have needs specifically within like the healthcare setting? What would be one gift that you would give to the next 10, 20 years of services for veterans?
The biggest gift I would give them is ease of getting what they need at the VA. I mean, to me, it's like if you didn't have PTSD before, in dealing with the VA, you'd have PTSD after. Just for disability, especially for disability. I mean, I know guys that should be 100%. And yet somebody there has read the little paper that he wrote and said, oh no. And it's really like a slap in the face. And to me, it's just appalling. If these guys, especially now that it's an all volunteer army, if they need help, they should get whatever they need. That's my feeling about it. Without any muss or fuss.
Streamline the services, right?
Yeah.
One of the things that I would hope that those who have been a part of this webinar would take with them. When you're working with veterans, there's a fine line between that which is therapeutic and that which is pragmatic. And you have to learn how to do that dance. Most of us who have been in service have a sense of accomplishment when we can reach a goal that we set out to achieve. It can't just be dealing with the emotional and psychological issues. It has to deal with the practical application of behavioral changes in one's personal life. I often used to say, you know, it's one thing to have a really successful session where somebody gains a lot of insight. But if that client goes out and doesn't apply any of that, it really becomes a waste of time. It almost becomes rent-a-friend and not really doing effective work in terms of one making some positive changes in life. And I think veterans really, really want that kind of experience more so than anything. I think it's important to look at that. Sometimes you have to be more mission oriented, if you would, to use military jargon. And I don't know if I'm making any sense about that, but that's a struggle that I think many veterans who enter therapy end up giving up because there aren't any positive changes that come out of it for them.
Yeah, great point.
I just think, and I'm more in generalities to our audience, the people that are taking this, and I think what everybody has to understand, and I know because everybody mentioned the VA, that not all veterans are eligible to the VA. Just because somebody's a veteran doesn't mean he's going to get help at the VA. So don't always look to the VA for assistance. It might not be there, but the veteran still needs assistance. And I think we also have to teach that to our veterans. You're not always going to be able to get into the VA. That's sad. Anybody that serves should be able to get into VA, but it doesn't work that way. And I think the clinicians have to know that, especially the ones that don't work in the VA healthcare system. And I think that's very important. I think that would help veterans not sit and wait for the VA to come to the rescue the veteran when he needs it right then and there, and then worry about the VA end of it. I have no idea if that's what you asked, but that's what I had.
Yeah, no, that's great. I just want to recognize our panelists for, being vulnerable and open and honest, and just the insights. And I believe that, we all learn from each other. So panels like this are completely invaluable to clinicians that are working in the space. And if you're not, you never know when someone's going to walk into your office and identify as a veteran. So you don't have to be someone who specializes in veteran services to make this relevant to you. It can be for anyone. It could be for primary care. It could be for a case manager, right? Like you veterans are out there. So when someone does identify as such, we hope that we give you information that's helpful in communicating and giving them the services that they need. So with that, thank you, panelists. As always, you're amazing. And yeah, so many great comments. Hopefully you'll be able to read through and see. And Amelia from NASW just put the evaluation link in the chat. And I'm going to turn this back over to her to close us out and let you guys know how to get your credits for this evening. Thanks so much.